Hey everybody, this is Dan Holden. I wanted to present my Capstone Project, which involved the monitoring of central line associated bloodstream infections at the University of Kentucky in Lexington. I worked with my preceptor, Jill Tobias, who is our facilities oncology nurse specialist and clinical nurse expert for the oncology service line. So I wanted to start by explaining exactly what central line bloodstream infections are. They can be defined as any contamination of catheters before insertion. This can be done by breaking sterility or an infection or a microbe being present on the skin and not being properly cleaned prior to insertion. Skin organisms, skin microbes can also migrate from the insertion site down the catheter and into the bloodstream, which can cause an infection. There can be contamination of the catheter by contact with dirty hands or fluids. This is pretty common with improper hand hygiene and not cleaning the hub of the catheter. Catheters can also be what's called seeded by other sources of infection. This is where an infection is already set up in another part of the body, from a ventilator or a surgical site, for example, and that infection can travel to the catheter and infect the catheter, and the infection may clear up at the surgical site or the ventilator, and it may reintroduce from the catheter. And then an extremely rare instance of contamination can actually be from the IV fluids themselves. So in order for an infection to be considered a CLABSI, there's 3 different criterion that must be met. I've only got 2 listed here because the third one is for neonates. So the first one, a recognized pathogen, has to be recognized from 1 or more blood cultures and cannot be related to an infection in a different part of the body. There also has to be at least 1 sign or symptom associated with fever, chills, hypotension, and again, this cannot be related to another infection, and a common commensal must be cultured from 2 or more blood cultures. The common commensal is considered Candida albicans, staph, Enterococcus, Klebsiella, Pseudomonas, or Staph aureus. So I wanted to look specifically at how our enterprise was impacting and reducing central line rates. So I teamed up with Jill and gathered some data and did some evidence-based research and found out that the CDC reports that a little over 30,000 CLABSIs occur in acute care facilities in the U.S. every year. And CLABSI is one of the most deadly hospital-acquired infections, with a mortality between 12 and 25%. So 1 in 4 people that get this and a catheter-associated infection wind up dying from it. Each CLABSI can cost up to $45,000 or a little bit more. And then reimbursement for the facility comes from the CLABSI directly affects 3 different repayment domains. The first of which is, of course, the hospital-acquired infection. The second one is PSA 90, and then CLABSI actually has its own repayment domain. So if a person winds up with eclampsia, we don't get reimbursed for any of the care that they have to receive to clear up the eclampsia. So I sat down with Jill to come up with what exactly she did for the facility. So in 2013, the enterprise as a whole kind of recognized that there was an issue with eclampsia and wanted to attack it head on. So they created a position for Jill to serve as the liaison for everything to do with Central Line education. So everybody that comes through general nursing orientation, the new physicians, anybody that has to do with Central Line care or Central Line insertion gets educated about how to prevent eclampsies. She also performs audits on Central Line care and reviews evidence-based practice, which a lot of the time that I spent with her was what I did, was reviewed the evidence-based practices that are in effect now. And then she also updates policies. Since she's taken over this position, we've done a couple of different things. We used to scrub our hubs with alcohol, and that's since switched to chlorhexidine scrubs, which showed a dramatic decrease in eclampsia rates. And we also do what's called hub-to-hub on BMT, where the saline lock that we usually have on IVs can't go on central lines because it's just another source of potential infection and where a microbe could live. So she came up with a Central Line bundle based on an article written by Harper, which entails a completed Central Line insertion checklist, which includes a timeout to ensure the right patient, and then it's just a checklist to ensure that sterility is maintained and a couple of different things. We also make sure that the correct dressing is used for all central lines. We check for dressing integrity, tubing and IV fluid bags with correct dates, and chloroprep or chlorhexidine baths have to be documented. So the audit that I mentioned earlier is performed by Jill or another member of the staff who's been trained. And there's a scorecard that provides a score for each quarter that the higher ups in our facility can review. So what she looks at during these audits is that the central line dressing is clean, dry, and intact, and that there's no way that any microbes from the skin can cause an infection down the catheter. And then we use what's called an Algodex antimicrobial disc. We used to use a biopatch, but what this does, it just serves as another barrier, as an antimicrobial to keep an infection from moving down the catheter. The central line is also dated and timed, and IV fluids are labeled and not expired. The CDC recommends that IV fluids hang for no longer than 96 hours, and the same is for IV tubing. IV tubing has to be labeled with hang dates and time and takedown date and time. And then the hibiclens bath, they have to be documented in our charting. And then the patient also has to verbalize how they are to take the hibiclens. The thing with the hibiclens is it's a cumulative antimicrobial, which means the more that you do it, the better the antimicrobial elements are for the bath, and the less likely eclampsia is to occur. So they're supposed to wet a washcloth and put the hibiclens on the washcloth, wash everything except for face and groin, and leave it on for 30 seconds and then rinse it. And one thing that really interested me was the central line patency. So one of the evidence-based practices that we have at UK is the central lines have to be flushed every shift with at least 10 mLs of normal saline with a pulsatile flush. And then after each blood draw, we have to flush with 20 mLs of normal saline. What this does is just prevents occlusion from occurring. And if we notice that there is an occlusion that has occurred, the nurses aren't empowered to use a thrombolytic agent such as TPA to break up that occlusion. One of the things with the occlusion is that the microbes can live on what's called a fibrant sheath or a biofilm, where even with antibiotic treatment, it's really hard to get in and kill those microbes because they form like a matrix that prevents the antibiotic from penetrating and killing them. Another sense of empowerment for nurses is to team with the interprofessional team to facilitate removal of unnecessary lines. This is one of the best ways to cut down on CLABSI rates. And if a patient needs a central line for TPN or chemotherapy or anything like that, a tunneled catheter is much less likely to cause eclampsia. So this is the scorecard that I was talking about, and this is for the enterprise directors to view and kind of base our effectiveness. And as you can see, after the evidence-based practice interventions, we dropped to near a 0 in fiscal year 2014. And here's just the numbers from that chart that show a 37% reduction from fiscal year 2013 to fiscal year 2014, which ultimately resulted in 8 fewer deaths related to CLABSI. And here are my references. Hopefully this was informative, and thank you for watching.